anti-fibrotic. So it protects the liver from PBC patients from getting more scarring, diminish the amount of inflammation from the cholangitis, and hopefully also translates from less cirrhosis down the road, which is sort of indirect evidence. It also helps if it actually regulates lipid metabolism. I don't want to get into it today with that, but I think the key thing is that it has a very potent anti-fibrotic effect on the liver. So we've come a long way. I think you've heard other speakers talk about immune system being revved up in terms of the cholangitis piece of PBC, the cholestasis, jaundice, and alkaline phosphatase elevation. And the drugs that I spoke about, ERSO and OCAR, are anticholestatic drugs. If you get full-blown cirrhosis, we don't have very good agents when you have cirrhosis, and there's a push for looking at anti-fibrotic medications that can be effective in these patients as well going forward. OCAR can be used in cirrhotics, and that's something that's also very important. So now I think I've set the stage for now really diving into liver transplantation to really understand the role of transplant in PBC patients. And some of them will be sort of review because I've sort of alluded to parts of it during the talk. When you have liver failure, we don't have dialysis machine that work in liver, so we go for transplantation. A lot of needed indications for transplant we'll talk about. There's an increase on the waiting list, limited donor supply. I was just chatting with one of the conference attendees about how he's from the UK. That's also a problem there. It's not just a problem in the United States. And there's also a lot of monitoring by the government in terms of liver transplantation. There are different types of transplantation of the liver. Autotopic is when you use someone passes away and they are dead, either from a stroke or motor vehicle accident or some major brain trauma. The liver is harvested. In that case, we call it cadaveric. It's autotopic because it's put in the right position where your liver is. That's on the right side, so that's the position of the transplantation. That's the most common type of transplant in the world. There's also living donor transplant. A few centers do that. There's also cell transplantation and xeno transplantation using animal parts to get transplanted. These are very experimental, but I think there's a big move that hopefully down the road, because of the organ shortage, that's something that we might need to look at. There are ethical issues, animal rights issues that really make it a very complicated area, but hopefully we should resolve those years to come. So this pie chart just shows you why do we do transplants. Majority of the pie is for hepatitis C. That's now on the decline because we have effective drugs. There's also fatty liver disease. That's actually soon to be the next big thing. PBC and PSC, the cholestatic liver disease, form about 10% of the need for transplantation. And as I mentioned earlier, since '88, among women, PBC is actually the second cause after hepatitis C. So PBC is a big deal among females. In our center at Methodist Hospital, transplant program, PBC patients in 2013 was about 2%. 2014, we had a much higher, slightly higher. That was about 6%, if I can see properly. That tells you that it's something that depends on where you live. I can tell you in Minnesota, they might have a bigger PBC population that they transplant and take care of. What are the indications for transplant in PBC patients? And again, if you have PBC and you have very marginal liver reserve, that means your liver is short because of decompensated liver disease, bleeding, internal bleeding, ascites, fluid buildup, confusion, peritonitis, renal failure, what we call hepatopulmonary syndrome, lung problems due to your liver disease, then you need to be considered for transplantation. When you have intractable pruritus from the PBC, itching quite a bit, or you have metabolic bone disease, that is something that although the bone loss rates after transplantation, after a point, it equalizes, and then you can build up bone. So sometimes folks who have bad osteoporosis, it might be an indication for transplantation, knowing that in the first few months, you could get into trouble, but then once the new liver takes hold, you can really build up new bone and have your bone strengthened. So it's a double-edged sword. It makes it worse initially, then it builds you up. So that's something to bear in mind. Malabsorption, vitamin deficiency would all be taken care of once you have a new liver. Liver cancer, we screen for that, and that really helps us diagnose it early to be treated. There are some patients who are not fit for transplant because they have medical issues that make it too risky to transplant. If you have overwhelming infection, or high pressure buildup in your lungs, we call pulmonary hypertension. If you have no social support, advanced heart disease, coronary disease, heart failure, very bad heart, you will not tolerate a major surgery like a liver transplant, in which case then you will not be put on the list. Or you've had, age is a relative contraindication. We transplant patients who are 70s if they are physiologically well, so age is not a contraindication, it's relative. We've had folks who are 70 who are as fit as people who are 40. You have 50-year-olds who have bad hearts and can't have a transplant. So age is very relative, and most centers don't use age as a cutoff. Absolute contraindications are active substance abuse. AIDS even is not a contraindication. It's also changed because AIDS is now well controlled. So we transplant patients with HIV and AIDS, and they do fairly well. So the exclusion criteria is changing. There are no absolutes. Age is not an absolute. HIV is not an absolute. And all those are becoming relative in terms of how well those patients do. So to come back to this slide, you have compensated cirrhosis, you are stable, you get a complication, you get into liver failure, and you need a transplant or death. So when you get decompensated, your lifespan shortens. This just shows you the probability of surviving. Those who have liver failure, over years, they have a very low probability of being alive. Median survival is about 1.6 years. That's those who have decompensated cirrhosis. Those who are compensated, who are stable cirrhosis, they tend to do a bit better compared to those with liver failure. So why does this matter? Because liver transplant actually saves those patients. This same graph on the left side I showed you previously, decompensated cirrhosis, they have a 25% survival at 5 years. When they get a transplant, that translates into a 75% survival at 5 years. So the chance of you dying or not making it, if you have 100 patients, only 25 of them will be alive in 5 years with liver failure. If they get a transplant, that same group would be alive, 75 out of the 100 would be alive in 5 years. So liver transplantation is life-changing. It really is amazing how some of the patients are very sick and they get back to their lives, their families work after having a successful liver transplant. So it's not experimental, it's actually very necessary for liver failure. So 1 year survival, if you survive your first year, you tend to do very well. It's about 90 to 94%. 5 year survival is about 75 to 80%. I'm going to show you the our center results from Methodist, just to give you an idea. This just shows you the different years, our survival rates, roughly about 90%, whereas our expected survival, in terms of how sick patients are when we transplant, our survival is supposed to be here, but we're actually much higher than expected in terms of patients' outcome. These are waiting lists. As you see, in 2010, we had about 200 patients on the waiting list, and with time, the waiting list has increased. And this same theme actually rings through for other transplant programs throughout the country. These are the transplants we've done over the years, 44 in 2010, and last year we actually had the highest in Texas, 116, with very good outcomes. So you can see that the numbers are increasing, and that's also seen in other programs. This is a wait list in the United States of America, about 18,000 pigs on a waiting list. Unfortunately, the number of transplants done per year is fairly flat, right about 5,000. So again, we need to really increase donor awareness, get folks to donate, and get their families to understand that they shouldn't rescind that donation card when it comes to donation, because that's very important in terms of saving lives. So you can understand that if you have patients on the waiting list that's increasing with time, and the transplants are fairly constant, we tend to have people dying on the waiting list. And again, about 10 to 20% of folks die on the waiting list because there are not enough livers to go around. And so that's something that we need to work harder at. Again, the waiting list to other states is more than 17,000 people. Liver transplant per year is about 5,000. And average wait time is quite long. It depends on how sick you are, but if you're sicker, you might get a transplant very quickly or not make it. So that's the dichotomy with that. So the vexing problem that sometimes comes up for our patients and their families is that who gets a liver transplant? How do we decide who gets a transplant? It's based on two distinct terms. Allocation means how do we allocate that liver to a particular patient? It's allocated on the basis of medical urgency, how sick you are. The sicker the patient, that patient tends to have the liver first because of the data I showed you about liver failure causing death as opposed to someone who is well compensated. So since 2002, we've based it on a MELD score. I'll get into that some more. And distribution tells you about how liver is divided into different geographic areas within the country. And again, we'll speak to that. Those who are on the list, if they get to a high priority within a particular region, will then get offered the organ first. Again, I'll explain this further when we come to it. So let's talk about allocation. Since the final rule, the government came out saying that we needed to increase the number of transplants, matching the need for transplant, the urgency of needing a transplant rather than you be on the waiting list first. So it's not the first to get on the list, but how sick you are on the list, that offer comes to you. And with that, they actually decreased the wait list mortality, which is about, initially was about 20%, is now more of 10 to 15%. So in 2002, they came up with this new allocation system in terms of allocating organs based on MELD, Model for End-Stage Liver Disease. It was initially developed to predict survival on patients undergoing a procedure called TIPS. And the Mayo Clinic actually had a very strong contribution to this effort. And that score helps us determine who needs a liver. So the sicker you are, the higher your MELD score. And this is a formula. I don't want you to memorize this, but you can go to the UNOS.org website, plug in your numbers, and it will tell you what your MELD score is. There'll be a test at the end of the conference. No, I'm just kidding. So if your MELD is low, your 3-month mortality, meaning that in 3 months, the chance of you dying is about 2 to 8%. On the other hand, if your MELD is 30 to 39, the chance of you dying without a transplant in 3 months' time is about 60 to 80%. And the MELD is above 40, the chance of you being around in 3 months is 0 without a transplant. So that tells you how powerful transplant is and why organs are offered first to these folks before getting to this level. At 10, you should not be on the list. We'll talk about that. You have to be a MELD of 15 before you get put on the transplant list. There are sometimes exceptions. Patients might have cirrhosis, PBC, for example, and they might develop cancer, liver cancer. If there's small cancer, liver transplantation can save them, so we get them on the list because of that. Or they might have other metabolic diseases or lung problems from the liver or high pressures in the lungs that are stable, and in those instances, we would also transplant them. More recently, the MELD score was altered a little bit just to advantage patients who are sicker on the transplant list. We call it a Share 35 policy, meaning that this was implemented actually a couple of years ago, June 2013, that they will share organs once your MELD is about 35 because you're very sick. So instead of restricting that sharing to maybe the Houston, Greater Houston area, if you're sick with a MELD of 38 and you don't have an offer within this region and there's someone in Dallas, an organ in Dallas, and there's no sick patient in Dallas who is above 35, you get that organ first. So that's what we call Share 35. And that actually helps save lives so that instead of folks dying locally because they didn't have offers, because they were sick, we could get offers from different regions. And again, we'll speak to that later. And this year, there was another alteration of the MELD. I think we are all, in this sense, trying to perfect a system that's not totally perfect, trying to tune it up, fine-tune it, so that we can optimize prioritizing patients who need liver transplants to get transplants. One of the known predictors of death among patients with cirrhosis is a low sodium level. So if you have cirrhosis and you have a low sodium level, that also is a very poor prognostic indicator, meaning it's got a very poor prognosis. And initially, those patients were not factored into the MELD, but more recently, that formula has been altered to include sodium so that if you have a low sodium, you would get extra points on the MELD score and hopefully get transplanted in a timely fashion so that you don't miss the boat. So the MELD is actually really gives it a prediction of pre-transplant death on the waiting list, and so it helps us select sicker patients for transplantation so that liver goes to the most ill patient and not the person who's been on the waiting list the longest. And again, it's very objective. The components of the MELD is your jaundice level called bilirubin, how thin your blood is, the INR, and how your kidneys are doing, the creatinine. So it's very difficult to really tweak that. And in the old system, it was very subjective, and so folks were getting transplanted when it wasn't their turn, and gaming the system was sometimes a problem. And again, coming back to our center, the purple bar shows you the listing criteria. A median MELD that we list patients in our program is about 18, and the average of the median of patients who got transplanted in 2013 was a median of about 32. That tells you that we're transplanting very sick patients. Again, fast forward to 2015 and actually sicker patients. In 2015, we are at transplanting patients who actually have an average MELD of about 37, median MELD of 37, telling that the MELD system seems to favor those who are sicker, which is the intent, that patients who are sicker should really get offers. But it again makes transplant programs, if you want to be successful, you should be very good at taking care of very sick patients for them to get a good outcome. So let's talk about, we've talked about location. That's the MELD, sharing organs, the sickest person getting the transplant. So how does the organ itself get distributed within maybe Houston? And that's distribution, part of the system. There are different geographic units in the country that have priority ranked, what we call, DSAs, donor service areas, which actually serve the different regions in the country. So these OPOs go out, look for organs, and then offer it locally to that region, and then expand it nationally. And in the United States, we have these UNOS regions. There are 10 regions so far. In Texas, we are region number 4. So when an organ becomes available, the region 4 folks, including Oklahoma, sometimes we forget Oklahoma, that's part of Texas. Sorry, just kidding. Nobody from Oklahoma here. Anyway, so we are all part of region 4, Oklahoma and Texas, so we share organs. And there is also push that hopefully this geography might change. It looks a bit like the red states and blue states, no, not to go there. But hopefully they're going to change it into maybe 4 regions so that there'll be wider sharing rather than regional sharing. And that brings logistics, more flights. You have to wait for an organ to come from New York to Texas, and that brings a lot of logistics. So they're modeling that, and the thinking is that in a couple of years that might change as well. So I'll be wrapping up. So issues of transplantation in PBC patients. Who needs the liver transplant? We talked about that. When to refer for transplant, I've alluded to that. Is the patient suitable for transplant? When to refer, once you have one complication of cirrhosis, you need to refer. You saw the outcome of liver failure if you don't get a transplant, if you have cirrhosis with liver failure or decompensation. If the MELD score is above 10, you need to refer that patient, and usually get listed when the MELD is 15. If the liver is poor, I mean very little reserve, jaundice, quality of life issues, if you have cancer, that PBC patient needs to have a referral for transplantation. So any of these complications would need a liver transplant referral. A refractory fluid buildup, confusion, fluid in the lungs would also need referral. In PBC patients, severe lethargy sometimes might be something that your doctor would talk to you about, that transplant could help that, but you need to be sick enough to get a transplant. So most times you might not get a whole lot of MELD points given that you're just lethargic. Your liver function might not reflect that. Irretractable itching, fluid buildup, severe osteoporosis I talked about could also cause that. And liver cancer could also be a need for transplantation. My time is up? 5 minutes, sure. Oh, sure. I'll wrap it in just a second. Let's see. So how do we go through the transplant evaluation process? Once your doctor sends you in, you go through an evaluation process. You see the liver doctor, the surgeons, the social worker. You do an image in study. You're listed if there are no problems, and then you then get on the list. If you have contraindications, nothing happens. Usually during the evaluation, you want to determine the cause of the liver disease, how severe liver disease is, and how, if you have any other medical problems or psychiatric problems or social evaluations. So in the history, we go through all the usual physical exam, blood tests, and then you might need an imaging to make sure you don't have cancer. And then the social worker would see you to make sure you have adequate support, you're not drinking, and if you're a substance abuser, you're in a good maintenance program, and your psychiatric disorder is stable. And then there's a medical review board that meets to determine whether you're a candidate or not. And if you're acceptable, you're put on the transplant list. If you're not acceptable, unfortunately, you just go with medical therapy. There are some folks who are not acceptable presently who need work to be done. Maybe they have heart problems that need to be fixed. If it's fixable, we'll wait for that to be fixed before you get a transplant. In terms of specificity for PBC, PBC patients do very well with liver transplants. We love PBC patients because they don't have hepatitis C that's going to come back, or Hep B, or alcohol. Very clean living, but it shows you my bias right there. The 1 year survival for patients with PBC is very good. 5 years is excellent. Because it's an immune-mediated disease, there's a higher risk of rejection. And unfortunately, about 15 to 20% of them might have recurrence of PBC in the new liver. So that's something that we usually use ERSO. And with a new drug, I'm sure there will be studies that will look at OCAR to see if that's effective. Excellent survival, but it can recur. So to wrap up, PBC is a very important cause of chronic liver disease. It's usually seen in middle-aged women. They might have other autoimmune diseases. It progresses in most patients, so you need to be mindful and treat them medically to protect them so they don't need a transplant, because it can be risky if you don't make it for transplantation. And once you get complications of cirrhosis, you need to really start thinking about transplantation. ERSO is the standard first line, and more recently, obeticholic acid or OCAR is used, sometimes in combination, or if you can't tolerate ERSO as monotherapy. And again, liver transplantation can really help those who have liver failure, and it really has a positive impact on our PBC patients. So I'll end here and ask for questions. Can anybody identify what this biopsy is from? It's a PBC patient.
We're going to have some questions. I've got 2 things.
Sure.
Number 1, I believe Houston has 3 or 4 liver transplant programs.
That's right.
And what is the benefit or what is the difference? And does Houston do cadaver and live donors or just cadaver?
Yeah. Good question. This question is, Houston has 4 transplant programs, all very close to each other, within a block of each other, kind of ridiculous. The question is that, does any of the centers in Houston do live donors? No, unfortunately. In Houston, we tend to have a big metropolis. We have more than 4 million people living in the greater Houston area, so there's not been a push to really do live donor transplant because we tend to get fairly good offers. The donor transplantation sometimes has some risk. I'm sure you heard about the donor deaths in New York, that a donor can actually not make it sometimes. It's a small percentage, but that's a big risk. There are programs that do live donors in San Antonio and Dallas, but those are highly restrictive and very selective process. So the vast majority of programs just do cadaveric transplant, meaning that someone has to die for their organ to be available.
My other question is with biomedical engineering, what is the possibility that a 3D printer will be able to create a liver to provide us with more opportunity?
Sure, good. Those are very good questions. Question is 3D printing for liver replacement. It's interesting. That's actually being studied very aggressively. They've done that in mice. There's actually a website, I'll try and give you the link, where they manufactured mice livers 3D that were able to sustain the mice models that were in liver failure for some time. So it's a very interesting concept. It's being looked at. There's a huge program at Wake Forest where they look at bioengineering. That's actually looking at that and other forms of bioengineering. So it's something that's being looked at, as well as xenotransplants using humanized livers that are being raised in pigs, for example. Pig can be your friend. It might grow your liver, and you might not have problems with rejection or medications afterwards. So, but there are ethical issues with that as well.
Another question we have is, what form of estrogen replacement is preferred? Pellets, pills, creams, patches, and how long should we use?
Yeah, it depends. If you're postmenopausal, it's advisable that you could use a patch. There's I'll say, a discrepancy in that most folks think that, if you're on estrogens, it's bad for your liver. If you don't have full-blown